Hey everybody, this is Dr. Jay Greenstein, and I am super excited today to talk about the evidence-based reporter findings, how research builds trust and trust yields care plan adherence. So I'm going to share with you three different versions of the reporter findings sheet that we built for our patients. The first one is very scientifically oriented. So what we do is we first speak to the patient about what evidence-based practice is. So we would say something like, Mrs. Jones, I just want you to know that the recommendations we make is related specifically to evidence-based practice, and that encompasses really three important elements. The first is the best available scientific evidence, the clinical experience of our doctors, and then also what your values and preferences are, and those things combined is really the essence of evidence-based practice. Then what we do is we talk about what the acute care guidelines or the chronic care guidelines look like in terms of both frequency and duration of care, how many times a week and for how many weeks, and then when they get a reevaluation for both acute and chronic conditions. So we would say something like, Mrs. Jones, you've got acute low back pain, so because of that, the scientific evidence recommends 3 times a week for the first 2 to 4 weeks. Now, because your pain is so severe, we're probably going to see you, we're going to plan on seeing you at least for the first 4 weeks, then we're going to reevaluate after the first month, and then after that, we're going to determine your treatment frequency, which most likely will be twice a week for 2 weeks and once a week for 2 weeks, then once every other week, and then once a month. We call this the withdrawal of care. We want to make sure that as we withdraw care from you, you're able to maintain the progress that we first delivered for you. Now, if it's a chronic case or a really severe case, we might say something like, Mrs. Jones, we're going to treat you 3 times a week for the first 6 weeks or 8 weeks, and then we're going to start withdrawing care there twice a week, once every other week, once a month. And when we're making these recommendations, we also talk about the short and long range treatment planning. So with pre-consultation duration of symptoms, if they've had symptoms more than 8 days, treatment time, according to the evidence, may take up to 1.5 times longer. And we'll say that, Mrs. Jones, you came in having this problem for the last 3 months. And what the scientific evidence tells us is that if a patient waits longer than 8 days before they come and see us, treatment time can take up to 1.5 times longer. So what we're going to do is we're going to recommend 3 times a week for the first 6 weeks, and then twice a week for 2 weeks, once a week for 2 weeks, once every other week for 2 weeks, and then once a month. Again, same thing related to severe symptoms. So with severe pain, recovery time may take up to 2 times longer. If they've had a bunch of previous episodes, 4 to 7 previous episodes, recovery time may take up to 2 times longer. And then, of course, injuries superimposed on pre-existing conditions can also increase recovery time by 1.5 to 2 times. So use all the factors in the patient's history and make sure you're tying that back to the recommendation that you're making for either acute or chronic conditions. Now, there's also other complicating factors. For instance, like the patient's age it can be a complicating factor. The severity of the mechanism of the injury could also be another factor. You know, ongoing symptoms despite previous treatment. They could have been to other healthcare providers. That might be a comorbidity, a complicating factor. So again, tying all that back into the recommendations that you're making helps the patient understand that you're using science to make a recommendation, not some nonsensical recommendation that you just want to get them in for care. Because quite honestly, consumers, and especially these days, they are skeptical. They know there's plenty of chiropractors out there that are just trying to get visits in their door. And so we need to make it clear, the folks that really care about the patients and are evidence-based and not just trying to sell a 100-visit care plan, that like this is how we deliver a recommendation to our patients. It's based on science, it's based on experience, and it's also based on their values. But here, in my opinion, is the secret sauce. At the bottom of this reported findings sheet is the data from the frequency dosing study published by Mitch Haas et al. So what they did is they randomized a group of low back pain patients into 1 treatment a week, 2 treatments per week, 3 treatments per week, and 4 treatments per week. So there are 4 different cohorts, 4 different groups of patients that were treated once a week, twice a week, 3 times a week, or 4 times a week. And of course, the patients that were treated 4 times a week had the greatest reduction in pain and disability. Next was 3 times a week, then twice a week, and of course, once a week had the worst reduction in pain and disability. So when we're making a recommendation to our patients, hey, Mrs. Jones, I want to see you 3 times a week, well, it's because we know that frequency of care, especially in the beginning of care, to reduce pain and disability really matters. So again, making these recommendations, tied to the evidence. Now, this is the very, very kind of nerdy science report of findings sheet, and it works really well. Some people really respond to all this data, all this information. But if you think your patients would respond to something that's a little bit more colorful, a little bit more, I don't know, marketing savvy, you might say, you might try this sheet. So this defines acute and chronic. It also has their primary diagnosis listed. What is the recommended treatment frequency and duration? And we break it down into 4 sections: initial care, symptom alleviation, and then after the initial reevaluation, care advancement, or really functional correction. And then after that, again, another reevaluation, the withdrawal of care, because the scientific evidence supports a withdrawal of care. And then lastly, wellness care. Now, there's really good evidence out there that supports maintenance care. And so there's at least 3 randomized controlled clinical trials that demonstrate that maintenance care helps patients, both in terms of pain and disability, better than patients who don't receive it. So we can make that recommendation to our patients. And then on the back side of this is the 2-page version. It lists the comorbidities, again, in a more kind of patient-friendly way. It doesn't look so like scientific-y journal piece, because the previous one that you saw, the first sheet that I showed you, those were literally copied and pasted from scientific journals. Then it goes into the data around the Haas study. Again, a higher treatment frequency at the beginning of care leads to a faster reduction in pain and disability. That's an evidence-based statement. You can say that with confidence. And adherence to your care plan is critical to achieving your healthcare goals. And then it has your recommendations that you'd be writing in for frequency and duration, how many weeks you want to see them daily, if you want to see them daily, how many weeks you want to see them 3 times a week, twice a week, once every other week, and then monthly. And then you can list your clinic hours Monday through Saturday, or if you see patients on Sunday, you can do that as well. And then the patient actually writes in their preferred times. We make the recommendation, we hand the sheet to the patient and say, okay, this is going to be your treatment schedule. Please write in the times that you want to come in 3 times a week, daily, twice a week, whatever the recommendation is that we're making. We work to get all of our new patients scheduled out their entire course of treatment the first day. First of all, we want them to understand and make a commitment to their course of care. Second of all, it's a tremendous amount of rework to chase patients when they need more appointments. We ran a 6 Sigma study many years ago. If you don't know what 6 Sigma is, Google it. We ran a 6 Sigma study many years ago, and we found that we could literally add thousands of dollars to our bottom line if we just scheduled patients out at the beginning of care. We've been doing it ever since, and it's been incredibly successful. And then the third sheet that I'm making available to you for free is a 1-pager. Essentially, it's the same exact sheet. I've taken out some of the fluff, I've taken out some of the pictures, but it allows you to, again, go through all the data. And I think a very customer-friendly way, you could see that the red and the orange and the yellow kind of match up with the frequency dosing on the Haas study. We do that on purpose because we want people to get through all the stages and get to green. We want to get their best possible outcome. And then again, the recommended treatment plan that the doctor puts in, and then the patient writes in their preferred times based on the recommended treatment plan. So there you have it. That's the evidence-based report of findings in a nutshell. Quick tutorial. It's something that you definitely want to be able to use if you're having problems with adherence, or if you want to improve your adherence. Maybe your adherence is pretty good, but you want to make it better. Helping patients understand the recommendations that you're making so that they trust you and they listen and adhere to their care plan to get a better outcome is critically important. And of course, if they're coming in for all their visits and they're adherent to their care plan and they don't self-discharge, what does that mean for you? Well, it means happy patients. It means a happy staff because they're not chasing patients, but it also means additional income for your practice. We ran another financial metric study 2 years ago. We looked at the fact that if patients came just one more time between visit 1 and visit 12 during a recommended course of care, we could add close to $500,000 to our bottom line. $500,000. So you might think that your adherence is pretty good, but if you look at your self-discharge data and you look at your PVA, your patient visit average, what you'll find is that if you can increase your adherence, you're going to increase income to your practice. And that's a good thing because you're delivering tremendous value by driving excellent outcomes. You might as well be paid for that. Listen, if you have any additional questions, feel free to email me at drj@kaizenovate.com. You're already on the online learning system, Kaizenovate Academy. We've got other courses available for you to help you in practice and in life. So please feel free to browse our course catalog. And lastly, feel free to check out our website at www.kaizenovate.com. We have lots of really cool stuff on our website, including all the technology that we're building, including custom mobile apps for chiropractic practices. Yes, I said it. We are building custom mobile apps for chiropractic practices. Check it out. It's super cool stuff. Our customers and their patients are loving it. So check it out. And feel free to reach out to me if there's anything else that you need. Thanks so much for joining me today.